Good evening, everyone. I just want to confirm that you can all hear me. So if somebody could just give me a thumbs up, and you just be sure that you can hear me. Okay, cool. I got 2 thumbs up. Thank you so much. Good evening, everyone, and welcome to tonight's Wax and Clinical. We're very excited for the next few Wax and Clinicals that we're going to be having. We're very lucky to have clinicians from across the Netcare group who are going to be presenting on some interesting topics. Today, we're very lucky to be having Dr. Daniel Surridge presenting for us. Dr. Daniel Surridge is the former head of colorectal surgery at Chris Hani Baragwanath Academic Hospital, and he currently heads up Johannesburg or Joburg Colorectal at Netcare Milpark Hospital. Dr. Surridge trained as an undergraduate at the University of Pretoria and then went on to do his general surgery at the University of Witwatersrand after his internship and community service. After completing his training as a surgeon, he then went on to further specialize in colorectal surgery at Wits, and he worked as a consultant and then head of colorectal surgery at Chris Hani Baragwanath until his resignation in 2022 from the state healthcare system. Dr. Surridge has trained in the UK, in Germany, and in Spain, and was the first surgeon in the state system to perform a transanal TME procedure, and the only colorectal surgeon in South Africa to have registered to use the speed burst device in complex polypectomy. Dr. Surridge has a passion for laparoscopic and robotic surgery. He also manages anal pathology and open surgery and is very experienced with complex endoscopic management of polyps. Tonight, he's going to be presenting to us on hemorrhoids and the management of anal pain. So without any further ado, I'm going to hand over to Dr. Surridge. Please note that we ask that if you have any questions, you can put them in the chat. We'll deal with them towards the end of the presentation, and that you please stay on mute during the presentation and keep your video off. And I just want to note that we have been trying to get Dr. Surridge's video camera to work, but tonight isn't the night for our cameras tonight. So we won't be able to see him, but you'll definitely be able to hear him. And then, if you have any questions, please post them in the chat and we will deal with them at the end of the presentation. Thank you so much. Dr. Surridge, over to you.
Thank you. Thank you so much for that kind introduction. Wow, it's lovely to see so many people here. So yes. See if I can get this to move now. There we go. So I left the state and I started to work here at Netcare Milpark Hospital, and we opened a colorectal unit, trying to sort of give everyone a sort of a one-stop shop for all of the colorectal issues. So we offered a number of disciplines in one space. And when I'm used to speaking to surgeons or to gastroenterologists. So when I was approached to give this talk, I sort of thought, well, we treat a lot of things that you aren't going to apply to everybody. And I kind of thought, what does everybody from, physiotherapy to GPs to gynecologists, surgeons, the guys in ICU, what is everybody going to have to deal with for a patient at least once in their careers? And it's the patient with a sore bum. Everybody's going to end up having to deal with this. And it can be quite daunting because it's sort of a part of the body that you don't really want to have to look at. And so, people kind of just brush these patients aside and sort of put everything down as being hemorrhoids. So very specifically, I've sort of put this talk together as being hemorrhoids and anal pain. And I'm hoping that by the end of it, I'll have convinced everyone that in actual fact, most anal pain is not hemorrhoids, and you actually need to look at these patients a little bit deeper. So to start off, what are hemorrhoids actually? So they are actually normal. Everybody has hemorrhoidal cushions. They're a completely normal part of your anatomy. They sit inside the anal canal and they have a function. So the function of the hemorrhoidal cushions is that if you imagine the internal sphincter of the anus, it's not like the shutter on a camera. So when you try to close off the anus and not have any stool leaking out, you need to imagine that internal sphincter being a little bit like an elastic band. It sort of squeezes and squeezes and squeezes until it can't squeeze anymore, and there's a gap in the middle. So it has to have something that it can squeeze on to seal the anus shut. And that's what the hemorrhoids are. So hemorrhoids are actually an organ that form part of your continence. So if you're going to go around cutting them out, you're going to affect your patient's continence. So the second lesson for today is don't go cutting out everyone's hemorrhoids, because they're actually quite important. So when we do finish up with patients with hemorrhoidal pathology, you sort of need to ask yourself, what is the cause of hemorrhoids falling out of your bum? And the problem here is, we actually don't fully understand this problem. So we've got a couple of theories. There's one that I subscribe to more than the other two, and I'll explain to you why in a moment. So the first theory that we have is, why do hemorrhoids prolapse, is the theory of venous pressure. So the hemorrhoidal cushion, just like your distal esophagus, just like your carpet medusa around the umbilicus, is a portocable shunt. There's no valves in any of these vessels. There's not, once the pressure rises, these vessels start to dilate. But the question you then have to ask yourself is, do patients with portal hypertension have an increased incidence of prolapsing piles? Because surely if that portal pressure rises, the hemorrhoids should fall out. And the answer to that question is no. And the reason for that is probably the reason for our next theory of why hemorrhoids fall out, and that is connective tissue damage. So unlike the other two, your distal esophagus and your carpet medusa, your hemorrhoidal cushions have got very dense, strong connective tissue holding them in place. So the veins around the distal esophagus just sort of sit there, and the moment the pressure rises, they'll dilate up. Whenever I teach students about this, I say you need to imagine a hemorrhoid as being like a balloon inside a checker's bag. So if you think the balloon is like a vein, the bag is like the connective tissue. You can blow that balloon up as much as you like. It's not going to get any bigger than the checker's bag allows it to. Unless you tear the bag, the vein won't, the balloon won't dilate, the vein won't dilate. So the second theory of why hemorrhoids prolapse is that you damage this connective tissue. And the way that we tend to damage this is by straining on the toilet or sort of pushing the connective tissue out. You can have actual issues with connective tissue in certain patients as well, and they do tend to have more hemorrhoids. So issues with collagen and elastin. There's this thing, if you have a look on the screen, called the Trites muscle, and that's actually just a continuation of the longitudinal muscle of the rectum. So occasionally when you do remove a hemorrhoid, you get this histology specimen that comes back and says, there's smooth muscle in your specimen, you've cut off the sphincter, and you shouldn't panic because there is smooth muscle in a hemorrhoid. It's normal, it's meant to be there. So yes, some patients do have a tendency to do this, some patients cause their hemorrhoids to do this. And this is the theory that I tend to mainly subscribe to, because it's the one that to me makes the most sense. It's the one that we're able to actually treat the best. The third theory, and this one comes mainly out of Japan, is that there's a vascular dysregulation. So the hemorrhoid, not only being sort of a portocable shunt, is also an arteriovenous shunt. So you've got a large artery or substantial artery that piles into the top of the hemorrhoid and supplies those veins as well. And for this reason, hemorrhoidal bleeding is usually very bright. So it's usually an arterial appearing bleed. And when they did some Doppler studies or some ultrasound studies of prolapsing piles, what they started to notice was that this hemorrhoidal artery was usually dilated in prolapsing piles. So they felt that this probably was the cause of why the piles were dilating. The artery dilated up, or why the piles prolapsed. The artery dilated up, and more blood flew into the hemorrhoid, and that's why it falls out your bum. The problem with this theory is that if you then take that hemorrhoid and you resect it, the artery comes down to a normal size again. So what this sort of implies is that the artery dilating is not so much the cause of the hemorrhoid falling out, but is probably an effect of when the hemorrhoid falls out, it requires an increased blood supply, so the artery dilates to accommodate that. In the Far East, they tend to subscribe quite strongly to this, and what they will do is they will actually take patients to theatre and ligate all of these blood vessels or laser these blood vessels off. And they do reduce the pressure in the hemorrhoid, but they don't actually put it back inside. So then we have to ask ourselves, what's the point of these theories? It's all nice and well to know maybe what might be causing it, but I've got the patient sitting in front of me. So clinically, when your patient walks into your rooms, what do they complain of? Almost all patients with anal pain will walk into your room and go, "Doctor, my hemorrhoids are sore." And this is because hemorrhoids have this reputation of being the only thing that goes wrong with your bum. So the patient will walk in and think, oh, there's something going on down there. I can't see it. I'm not going to ask anyone else to look at it. So according to me, it must be my hemorrhoid that's sore. And almost invariably, hemorrhoids are not painful. So a plain prolapsing hemorrhoid that's just fallen out of your bum will usually present with a bit of itching, some discomfort. It can feel a little bit moist because you tend to have leakage from the rectum, and they might feel something falling out of their bums. It's almost always not painful unless it has thrombosed. A thrombosed hemorrhoid for sure, that's really, really sore. But unless it's thrombosed, they're usually not sore. And a thrombosed hemorrhoid will look like a great big shiny bunch of grapes, and a normal soft prolapsed hemorrhoid that's usually not painful. We then wanted to have a look and see how we could classify hemorrhoids, and we used to sort of say hemorrhoids are internal or external. That classification system has disappeared. So we now talk about grade 1, 2, 3, and 4, and it's pretty simple. Grade 1 is the old internal, grade 2 means they prolapse and they disappear by themselves. Grade 3 means they prolapse, you have to push them back in, and grade 4 means they prolapse and they're never going to go back in. Doesn't matter what you do to them, they're out. This will become a little bit more relevant later when we come to treating hemorrhoids. And just as I said, on a point about it, we no longer talk about internal and external hemorrhoids. We talk about the grading system. And then there's this thing called perianal veins, which can also clot. So if you have a patient with sort of pain around the anus, and they come in and they've got sort of this hard lump that's sitting just away from the anal verge, it's usually a centimeter or two away from the anal verge, that's a thrombosed perianal vein, and that's not actually a hemorrhoid. Complicated hemorrhoids, however, they can cause other issues, and this is not your plain prolapsing one. These are thrombosed ones. They can bleed, and they can bleed quite a lot. So when you have the rectal mucosa falling out of the anus, if they wipe that with the toilet paper, they will spray blood into the toilet bowl, and it will look like someone slaughtered a pig in there. It's dramatic, and patients faint, and it looks like a lot of blood. It's usually not life-threatening. I've had 1 or 2 patients who've dropped their HP from hemorrhoidal bleeds. It's almost invariably not that. You can see spots of sort of necrotic tissue on the side of the hemorrhoid that they don't normally cause any major infection, and they will usually heal by themselves. You can manage this without having to panic or to do anything about them. So, as I said before, one of the things that I want to drill home for you is that we should stop operating in hemorrhoids, because when I studied medicine, this was chanted regularly by the general surgeons, and that was that hemorrhoids are bread and butter for the general surgeon. The moment your patient came in with hemorrhoids, the patient was whipped off to theatre, hemorrhoids were taken out, and I could pay to send my kids to private school. This is completely wrong. Okay, we should not be operating on these anymore. There are far better ways to treat these. And this approach to managing hemorrhoids is the reason that patients do not seek help, because surgery for these things is incredibly painful. So the patients will wait and wait and wait until it's really bad before they seek help. If we can change the mindset around managing these, patients will come and seek help sooner, because they know that it won't be as bad as oh, I'm just going to be taken to theatre. If you are going to have to take your patient to theatre, there are the traditional sort of surgical operations. I'll run through these very quickly. There's the Milligan-Morgan. This is an operation where you cut your hemorrhoid off, you'll ligate the artery at the top, and you leave the wound open. This is what most surgeons in South Africa will be doing. It's what most of us are taught. We regard it as being safe because the wound's open, it'll heal from the inside out, so you'll have less chance of an infection. The Ferguson is a similar operation to that, but instead of leaving the wound open, you stitch it closed. We get a little bit twitchy around this because we worry that we're going to have to stitch sepsis inside. This is quite a popular operation in Germany. They claim that they don't have too many issues with it. I've not seen anyone here doing it, but it's an intriguing option because it should have less pain, but we do worry about the infection. Park's procedure is an interesting procedure where instead of cutting the hemorrhoid out, you make an incision around the anus. You dig the hemorrhoid out from under the skin, and then you close the skin sort of on the edge of the anus. You never actually cut inside the anus. Issues with this is that you tend to devascularize that skin, so it tends to slough off and open up anyway, and they have pain and issues regardless. I'm not aware of anyone who's doing this. The Whitehead procedure really should be relegated to the history books and should not be performed at all. There are a few pockets of sort of specialized centers that might do it. This is a procedure where you will go all the way around the anus, cut the whole mucosal dentate line off, and suture it all together. The problem with this procedure is that they tend to get Whitehead deformities, where the posterior line falls out again, and they also tend to get stenosis because that's the stricturing of the line closes the anus up again. So this one really shouldn't be done anymore. What we're trying to do now moving away from, when I was a medical student and the professors had cut everything out, as we're trying to move now for a painless, durable, rooms-based procedure where patients can come in, have their hemorrhoids managed, and walk out again. And that's when we started getting things like sclerotherapy, where you can inject a sclerosant into the base of the hemorrhoid. Now, this takes a little while to work because you have to wait for the scar tissue to set in, pull that hemorrhoid back up. There's low voltage electrotherapy. Now, these are quite fun. It's a machine called an Altroid. You can use it in your rooms, and what it is a very low electrical current that you pass through the base of the hemorrhoid. And by doing that, you kind of disrupt the tissues and you cause scar tissue eventually, and it pulls the hemorrhoid back up inside. The problem with this is that you have to hold it in position for 15 minutes at the base of each hemorrhoid, which will take up your entire day, will mean that your patient has something stuck up their bum for about an hour, hour and a half. And I don't think anyone's really able to sort of make this guy work all that well. Rubber band ligation is actually very popular. This is quite good for patients where the main complaint is bleeding. It's relatively painless, but it's not good for prolapsing hemorrhoids. The Hemorrhoid procedure, this is one that I will normally use for my patients who have got prolapse of the rectum, the rectal lining outside of the anus. This is one where you go and you ligate that artery that supplies the hemorrhoid, and then you run that stitch down in the hemorrhoid, and you tack everything back up inside so that it pulls back to where the hemorrhoid should be. So there's no cutting, no loss of tissue. The hemorrhoid just goes back to where it's supposed to be sitting so that it can function again as an organ of continence. The PPH was an operation designed in Italy where the idea was to cut or remove a cuff tissue from just above the anus and the rectum, and pull, by removing that tissue, you pull everything back up inside. So you remove the cuff of tissue, you staple it all together, and it hauls the hemorrhoid back into the anus. Problems with this procedure was that they found it's quite tricky to get that staple line right, because it has to be in an absolutely perfect position. If you go too low with the staple line, your patient will have complications of pain and sepsis. If you go too high or you take too much tissue, your patient will have other issues of shortness and stricturing and things. There are instances of patients dying because of this procedure, because of if you take too much tissue into it and you remove a piece of the rectum, you can have a leak that tracks up retroperitoneally into the thorax and gives you myocarditis, mediastinitis. So there are case reports of this happening. They're not a lot, but there are a few. So this has sort of lost a lot of popularity, but it is done in a few centers. Embolization is a new kid on the block. So embolizing hemorrhoids, going down and embolizing that artery in the veins that supply and drain it. This one is becoming more and more popular because it's radiological. You can do it through a catheter in the groin. The problem with it is it does make the hemorrhoids deflate, but it doesn't put them back anywhere. So remember when I said the question is whether this the hemorrhoid is an issue with the venous pressure, arterial pressure, or whether it's an issue with connective tissue. This is the operation that really points you towards, it's probably a combination of all of them, but there's a really big issue with connective tissue in this operation. They don't address the connective tissue at all with this procedure. So what your patient will have at the end is sort of a flap of skin that hangs out of their bum that's a bit deflated, but the hemorrhoid doesn't go away. So now we've got this huge collection of operations and procedures and things we can do for patients. And you're sitting here going, oh, that's really nice. What do I do with all of this information? So right off the front, we divided our hemorrhoids into grade 1 to 4. And this kind of gives us the approach of, what can we do for each of those? So sclerotherapy, infrared or electrocoagulation, those can go into the sort of the lower grades. Grade 2 and 3, you can rubber band, you can Doppler. The stapled hemorrhoidopexy really is for grade 2 or 3, and the surgical procedures, the bigger excisional hemorrhoidectomies, the bottom line there, those are for your bigger hemorrhoids. The problem with this diagram is that the line I've left out is the one right at the top, and it's not in color. The block is not colored. It's in white, so that you don't notice it so much, and that's called conservative approach. And that's actually the most important part of this is, when the patient comes to see you, you need to ask yourself a few questions, and that is, what are you actually treating? Hemorrhoids are not life-threatening. They're not going to kill the patient. It's more of a lifestyle issue that you're trying to manage. It's not that this is going to end the patient's life early. It's that you're trying to make their life better. So what is the cause of the hemorrhoids prolapsing? And I've said I subscribe to the theory that it's mainly got to do with connective tissue. And that is usually got a lot more to do with toileting habits and straining and pushing those hemorrhoids out. So very few of the operations and above address the cause of that connective tissue damage. They might address the connective tissue injury, but they don't address the cause. So none of these operations fix the cause of hemorrhoids. I can do as many hemorrhoidectomies as I like. If I don't treat the cause, there's a chance those hemorrhoids are coming back. So you then have to ask yourself, what are the symptoms? And really, when you're managing a lifestyle issue, you need to treat the symptoms and get on top of those. So the American College of Gastroenterologists came out with this. And I found this the most practical one. That was your initial evaluation. I don't think you should be doing an endoscope for all of these patients, but you need to examine your patient thoroughly, have a look at what's going on, take a proper history. And your first line treatment is dietary modification, fiber, and how to go to the toilet. And I think that is the most important thing to take away here is when you're managing hemorrhoids, you've got to treat how the patient goes to the toilet or the hemorrhoids are going to come back. Then you can look at office-based procedures, you can look at surgery, you can look at big hemorrhoidectomies, you can look at pain regimens and things like that. But the very first thing you have to do is treat those toileting habits. Now, how do I do that? Okay, I send my patients, and often I'll send my students off to YouTube to look for something called Squatty Potty. Now, Squatty Potty is an American invention. It's very expensive, but you can buy similar things to this in South Africa. And the idea around the Squatty Potty is that in the pelvis, you have the puborectalis muscle, which tends to pull the rectum and the anus at 90 degrees to each other. The moment you flex your hips, you relax that muscle. So human beings were never meant to sit on a toilet to defecate. We were supposed to squat. And the Squatty Potty movie has these beautiful animations that show you exactly how that muscle works. The moment you flex your hips, you relax the muscle, you straighten up the rectoanal or anorectal junction, and your patient's able to pass stool far easier. And this is something really simple that you can literally tell your patient how to do. I have a little form in my office that I give to them and say, this is how you should sit on the toilet. Okay, and a lot of them will go home, try this out, come back a month later and say, you know what, the bleeding has stopped. I'm not feeling so bad anymore. I'm going to do this from now on. The second thing, also on YouTube, that I'll send my patients to is this thing called Mujipoo. So what the Mujipoo method is, when you consider how patients strain on the toilet, they'll sit and they'll perform a Valsalva. And the Valsalva means that they are contracting their rectus abdominis muscles. Now, the innervation for the rectus abdominis muscle is pretty much the same as the innervation for the pelvic floor. So the moment you contract that rectus abdominis, you're actually contracting the pelvic floor and closing the anus off. So they're effectively pushing against a closed exit. If they sit on the toilet with their feet up on their Squatty Potty or pile of books or box or stool or whatever they've got, and lean forward a little bit with a straight back like the lady is sitting there, and they say, whenever they feel the urge to push, instead of pushing, they say, moo, like a cow. Okay, that sounds hysterical in their bathroom in the morning, but it really does work. It helps to relax the rectus abdominis, it relaxes the pelvic floor, and they're able to pass the stool out far easier. And these are literally the two things that I tell my patients to do in the toilet. Anything else that I do for them? Hydration. Now, there's a lot of literature around hydration saying that it does not improve, defecation or constipation because you just pee it out. And for that reason, I will always talk about fiber as well. So you need to have fiber inside your gut in order to hold that water. So fiber, and more fiber. When we discuss fiber with patients, we'll glibly sort of say, oh, you need more fiber in your diet. And they'll go off and they'll go, okay, I'll have bran or something now. What we never do with them is we never discuss soluble and insoluble fibers. Now, your only really good source of a soluble fiber in your diet is rolled oats, plain rolled oats, not the instant oats, plain rolled oats. Banana and avocado has a bit. Another one is this fiber gel. If you have a look at the fiber gel supplement, the main ingredient is something called espagula husk. It's on the screen there. Now, espagula husk, you can buy great big bags of it at Discam or at a health store or other places. What I've now taken to doing is actually saying to my patients, just go and buy this husk. Have a teaspoonful in yogurt or in a smoothie or something in the morning, and then you're good to go for the day. And once again, lots of fresh fruit and veggies. And that's how I manage uncomplicated prolapsing hemorrhoids. The only patients that I really end up operating for hemorrhoids is the patients who have their rectal lining falling out. And even those, I don't operate all of them. I only really operate the ones who have bad bleeding, as in I'm walking down the street and my pants fill with blood. So there's a few of them that I will offer surgery to. I almost never operate on hemorrhoids otherwise. When do hemorrhoids hurt, however, is when you have the thrombosed piles. Now, these patients are obviously in a lot of pain, and you need to approach them very carefully. So when you have a look, they've got a big lump hanging out their bum. It's bright, it's shiny, it's sore, they're in pain. And most of them I will manage with topical nitrates, and they need to understand that the nitrates must go into the anus, not on the hemorrhoid, because what we are trying to do is to relax the internal sphincter and allow the hemorrhoid to heal. I'll give them laxatives and analgesia. If, and only if, that hemorrhoid is less than 72 hours old, you can offer that patient a hemorrhoidectomy. Now, I've had, of all the patients with this that I've seen, I've had one patient opt for surgery, because most of them, if you explain to them that I can take you to theatre, I can do a hemorrhoidectomy and you'll have pain for 2 weeks, or we can give you the topical nitrates, you'll have pain for 5 days, but the lump is going to stay there for the next 6 weeks until it heals, most of them will opt not to have surgery. And I think that the big caveat to take home here is that the hemorrhoid will heal. Regardless of what you do, this hemorrhoid's going to heal. It's not like you're going to go in there and fix it. The body will heal it. All you need to do is help it along a bit. So there is an option here for surgery, but not everybody needs it. So from my side, the take-home message again is stop operating on hemorrhoids. So if hemorrhoids don't really cause all that much anal pain, what does? And by the way, this is a photograph that I took at Baragwanath Hospital. And here, this is how we innovate in South Africa. I did wonder why we didn't just turn the dustbin lid the other way up. But anyway, maybe it stops patients falling off. But what does cause anal pain? And these are the things that do. Fissures, abscesses, fistulae, cancers, and fecal impactions all cause anal pain. So if we unpack these ever so slightly, one by one, nuclear fission, and the reason I put this up is being the atom bomb, okay, it's not all got to do with that new movie that's out, the Oppenheimer movie. It's also got to do with anal fission. And this is probably the most painful thing that we deal with in colorectal surgery. I've had patients come in with this saying, Doc, my hemorrhoids are sore and they cannot sit. They're kneeling on the floor in front of me because they can't actually sit on their bums. And within 10 seconds, you know that it's not a hemorrhoid. This is a fissure, and fissures are properly sore. And the pathology of a fissure is essential to being able to treat it. And what happens is you start off with a crack in the anoderm, and per definition, this crack has to be deep enough to expose the internal sphincter. So your fissure will open up, it will expose the internal sphincter. What happens is the internal sphincter then goes into a spasm. That spasm cuts off the blood supply to the crack or the tear. That tear then stays open because it can't heal, there's no blood supply to heal it. That keeps the sphincter in spasm. The spasm reduces the blood flow keeps the wound open, and then it forms this vicious cycle that keeps on and on and on going. Patient will say, every time I go to the toilet, it feels like I'm ripping open from inside and passing razor blades. Early on in it, so in the first couple of weeks, again, these things bleed. They bleed a lot. The toilet bowl is full of blood. Once they've been to the toilet, they manage to pass something, their pain usually changes to a burning sensation. And that burning feeling lasts for hours and hours and hours. So when you see your patient, they often look like this. And this is why people mistake fissures for hemorrhoids. Because if we go back to the diagram, there's something called the sentinel skin tag there. And what this is at the top of the fissure, there's some inflammation of the skin. And that sits there and it blocks your view of the fissure. All you need to do is sort of pull that skin tag a little bit down and hey presto, there's your fissure. Once you see this, stop. You've got your diagnosis. You don't need any more. Do not put your finger inside this patient's bum. All you're going to do is hurt them, and you're not going to get any more information than you need. Treat the fissure from this point on. And how do we treat them? Stool softeners, once again, topical nitrates. They need to crush. I use Esmo because it's a little more stable at room temperature. You can use Angised, any of these nitrate preparations. Crush them, mix them with an local anesthetic ointment, and explain to the patient it has to go inside the anus, not on the sore part, inside onto the internal sphincter. You want to get that internal sphincter to relax, to allow the body to heal the fissure so that the blood can flow and heal that fissure. If they're not tolerating the nitrate, because even though you put it in your bum, sometimes it can give you headaches. You can try using the nifedipine instead of the nitrate. If they're not able to do this, you can try oral Viagra. So oral Viagra will also relax the internal sphincter. The problem is that in South Africa, we don't have a 5 milligram preparation of Viagra. We only have a 20 milligram. However, there is a 5 milligram preparation of Cialis that you can try. Medical aids are not going to pay for that. And the pharmacist will look very strangely at female patients getting Cialis, but it does actually work. If that doesn't work, so if you try your topical nitrates for a good month and the patient's not better, you can double the dose of the nitrates. So you can use 2 tablets once a day. If that still doesn't work, then you take a patient to theater and you inject Botox into that internal sphincter. Now, we know we can cut up to 1/3 of the internal sphincter and the patient will remain continent. So if you Botox the length of the fissure and just paralyze that piece of muscle to allow it to heal, your patient will be continent even though you've injected Botox into those muscles. There's something called a Lord stretch, and I put it up there just so that people don't do it. This used to be a manual stretch of the sphincter. It's an awful operation. It causes incontinence and it causes injury to the pelvic nerves and chronic intractable pain syndromes of the pelvis. So don't do that. If Botox doesn't work, try Botox again. If it still doesn't work, try Botox again. If it still doesn't work, then you can look at doing the lateral sphincterotomy. The lateral sphincterotomy, you will cut the internal sphincter for the length of the fissure. And that allows it to relax and to heal. If that doesn't work, you can repeat it on the other side, so the other lateral side. And usually this is a permanent thing. So my concern around the lateral sphincterotomy is that as we age, our connective tissues loosen up. So I don't know whether a lateral sphincterotomy will have an impact on a patient 40, 50 years down the line. As I said, we know we can cut up to 1/3 of the sphincter and the patient will remain continent. You can develop complications from these fissures. They can develop abscesses and fistulae, and those you will need to manage on their own merits. Fistulas are a slightly different story. Fistulas tend to develop from abscesses, and this is the cryptoglandular theory. If you have an abscess in the anus that will, when we take them to theater, we drain the abscess or the abscess bursts. That then means you have a fistula going from inside to outside. Other medical diseases that can cause fistulae that we often need to keep at the back of our mind is Crohn's disease, TB, and chlamydia is a bug that can do these. They're fairly rare. Most of them are cryptoglandular. And your cryptoglandular theory is this. You have, in the dentate line, a duct that travels to a gland that sits between the two muscles. Now, if you block that duct, and we actually don't understand why the duct becomes blocked. We know that it happens more often in smokers, but smoking is not a cause. We also know that this only happens in humans and dogs, so no other animals have this problem. But if you block that duct, you essentially block a one-way flow for that gland to drain its secretions. The gland will still produce secretions, they will just stagnate, and that's when you develop the perianal abscess. That abscess will then burst through the muscle to try and find its way to the skin. You then take a patient to theater, all that abscess bursts, and you then have a fistula that's draining from inside the anal canal to outside the anal canal. Now, fistulae are, speaking as a colorectal surgeon, are without doubt and absolutely the hardest thing to manage in colorectal surgery. I would rather treat cancer than treat this. This is a very, very difficult condition. Typically, what your patient will complain of when they have a fistula is usually there'll be a history that somewhere in their past they had an abscess that either burst or was drained in theater. And then they'll say that they were better for a while, and then they found that they had this swelling that got big and sore and hard, and then it burst and pus came out and they felt much better. And then it happened again, and then it happened again. And they have this cyclical pattern of sort of swelling and then rupture, swelling and rupture. And what's actually happening is that the skin of the perineum is trying to heal, and once the fistula or the abscess ruptures, the skin will then heal and the abscess will recur. So in order to treat that, we need to drain it. If you Google operations for fistula and ana, there's literally hundreds of operations, hundreds. And what that really means is none of it works. None of the operations work. If we had an operation that fixed fistulas, we would all do it. But there's no good operation, and all of them pretty much have about a chance, 60 to 70% chance of success, and there's a 30 to 40% chance that patients will have to live with their fistulae, that we just cannot get them sorted. The basic principles of managing fistulae is that you must drain that sepsis, because otherwise they carry on with that cycle and they can complicate further. And you must preserve their sphincter function. You don't want to make them incontinent. So what we normally do is we will drain the the fissure with a seton. There's different types of setons. I use a draining seton. Some people may use a cutting seton. I will then allow it to settle, and I'll deal with the tract afterwards. If the patient has Crohn's disease, completely different kettle of fish, drain the infection, treat the Crohn's. If the patient has chlamydia or TB, drain the abscess and treat the underlying infection, and they'll usually settle down. Fistulae can complicate with abscesses that don't only go into the perineum, but they can track up into the pelvis. You see there's those extrasphincteric and suprasphincteric fistulae can also form abscesses up next to the rectum. I've got a patient that I saw yesterday who has an abscess that's sitting all the way up in the presacral space from a fistula, so they can really complicate quite badly. A draining seton, this is what I normally use to treat my patients. And if you treat it, I use something a little bit, it's not quite as horrible as this. It doesn't have knots and things. It forms a smooth band, but this is the idea: is you put it in, you keep that hole in the skin open, and you allow that pus to drain out, and for that fistula to settle down. Moving on to anal intraepithelial neoplasias. So this is the precursor lesion to anal cancer. And if you have a look at the symptoms of it, the patients come in complaining of itch. They have a bit of discomfort. It feels a bit moist. It might bleed a little bit when they wipe. And if you think about it, this sounds like something familiar. This sounds like a slide we had a few slides ago. This sounds very much like the symptoms of patients with hemorrhoids. And this is a real bugbear for colorectal surgeons, is that you'll have a patient who comes in and says to the doctor, "Oh, doctor, my hemorrhoids are itchy or uncomfortable." Doctor gives them sherry product. They go off, they come back a few months later, "Oh, doctor, my hemorrhoids are playing up again," gives them preparation H, comes back a few months later, and then a year or two later, they say, "Doctor, I've got a lump in my bum." Someone finally looks at them, they've got cancer. So we see this time and time again, that if you don't look at the lesion, you're going to miss it. And the thing with the lesion is, these guys will look, although they're caused by HPV, they will look almost like flat, hyperpigmented spots, almost like moles, but they're flat. They don't form great big cauliflower lesions, so condylomata look very different from these. The HPV viruses, the sort of the 16s and 18s and 56s that cause this, are usually not causing great big exophytic condylomatous lesions. They cause flat lesions that are just darker, and those you need to worry about. So it is a precursor to anal SCC, where we grade them now according to the high-grade cells and low-grade cells, just like you will grade a cervical intraepithelial neoplasia. And they kind of fit into the same category of how we need to manage them. Of the low-grade cells, about sort of 2 to 5% might progress to cancer. The high-grade cells, 20% will progress to cancer, so those ones you need to remove. The low-grade cells we can usually manage with topical therapy, and the high-grade cells we need to cut them out. Anal cancer is caused by HPV. It has a very strong association with HIV, and that has to do with infectivity. We can get 50% cure of them with a chemoradiotherapy called the Negro regimen, and that we usually manage to sort of spare about 50% of our patients' anuses. The rest of them will lose their anus and their rectum in order to try and get that cancer out. Now, these guys will present with a hard lump. It usually is painful, and it usually is bleeding. So these guys need to head off to a surgeon as soon as possible. Other malignancies, and these guys are really weird ones you can have down in the anus: lymphomas, melanomas, sarcomas. There's some other pink canaries that are out there. The lesson to take out of this is look at your patient and see what's going on down there. Not every patient walking in the door who says, "I've got a sore bum, has got a hemorrhoid." Fecal impaction. These guys complain of pain because they've got a rectum that's stuffed full of stool. Now, the moment the rectum dilates, or the rectum is sort of stretched, then the anus will dilate. And that then causes that stool to sit on the anoderm, or the skin of the anus. Now, the skin of the anus has more nerve endings than your fingertips, so it is incredibly sensitive. These patients will usually come in complaining of incontinence. So they'll say, "I'm leaking diarrhea, I'm leaking diarrhea." And patients will go, "Oh, he's incontinent to diarrhea. We'll give him something to make the stool soft, give him Imodium." And unless you examine them and put your finger in their bums, you will only then realize that what's actually happening is they've got an impaction, and they've got a leakage of liquid past the impaction, and that's what's coming out of the dilated anus. So you need to examine these patients as well. And the moment you empty out their anus, sort of give them a few days to settle down, that pain disappears. The last one that I do want to talk about is pruritus ani. And this is one that I think, we don't pay enough attention to, and our approach to it is really muddled up by what people tend to write. Pruritus ani, or what's literally itchy bum syndrome, is what it means. Is the patient comes in and says, I'm so itchy down there, I can't stop scratching, and then it gets painful, and then it bleeds, and it gets itchy, and then it gets painful, and then it bleeds. Almost always, what's the problem with these patients is that they are over cleaning. They are just fiddling with their bums too much. When you read the books and the papers about this, they'll talk about worms, and they'll talk about eczema, and they'll talk about this, that, and the other thing. So, we all have this algorithm, I'll treat their worms, and then I'll treat their eczema and other things, and none of it works. And your patient still comes back saying, I've got an itch, I don't know what to do with it. When you see this patient and you have a look at them, you'll see that the skin looks a little bit thickened. It's usually a little bit sort of paler than the skin around it. And you can see that it's been damaged by them scratching it. First thing to try with them, before you give them a Vermox or whatever it is that's on the algorithm, sit down with them and ask them, how are you cleaning yourself? And they'll say, I wipe with paper, and then I feed the soap in the shower, because most patients then sort of go, he thinks that the doctor thinks that I'm dirty and I'm not cleaning enough, and that's why I've got this. So they'll usually sort of overdo what they normally do. I had one patient once say to me, I scrubbed my anus with a loofah. Now, loofahs are incredibly abrasive. And I actually had to do a double take and make sure what was the patient was talking about. But once you sit down and you talk to them and you say, look, you're damaging yourself. And what's happening is you've got an itch, you're then scratching and causing more damage, and it's trying to heal, and that's what gives you the itch. And then you scratch it again, and you're stuck once again in a vicious cycle of itch and scratch and itch and scratch and itch and scratch. Stop scratching, and the itch will go away. And it's hard for people to do that. So they need to remove any sources of what could be itching. So they've got to stop using soap, particularly any soap that has a perfume in it. So what I say is, if they have to use something, they can use aqueous cream, so unperfumed aqueous cream to wipe to clean their anuses. They've got to stop wiping. So if they're sitting on the toilet, they can take toilet paper, they wet it, they dab it with wet toilet paper, and then they pat it dry with dry toilet paper. And that's it. No wiping, no scratching. In order to get them to the point that they can do this, I'll give them a week of a low-dose topical steroid cream. What I do is I take Dovate, 25 micrograms, and I mix it with 25 milliliters of zinc oxide cream, and they apply that twice a day, but only for 1 week. If they do it for longer, they start to thin the skin and damage the skin more. Once that week is up, I swap them over to a nappy rash cream. So I usually give them Pseudo Cream or Bennett's Baby Bum Cream, and that then gives them a barrier. And by that point, the itching has stopped, they've stopped scratching, and now they're more comfortable. And they can carry on with that, with the nappy rash cream for as long as they like. I have once, I see a lot of these patients, and I have once been caught out by a patient who actually had a fungal infection. Almost all of these patients are a problem of overcleaning. There's a professor in Cape Town who says that the anus thrives on neglect. Leave it alone. Stop cleaning it. It doesn't need to be squeaky clean. Doesn't matter if there's a bit of poo down there. Just leave it alone. And this is what these patients need to understand. So you spend a bit of time with them, explaining to them how to clean properly without damaging themselves. So from my point of view, take-home messages are: stop operating on hemorrhoids. Always examine your patients for the cause for pain and treat the cause. Don't just randomly go out there and operate on everything that comes in the door. Or assume that every patient who comes to the door with a sore bum has hemorrhoids. Most uncomplicated prolapsing hemorrhoids are not painful. If your patient is in severe pain, it's usually got a different cause. So go look for that other cause and treat that rather than treating the hemorrhoid. Thanks a lot.
Thank you so much, Dr. Surridge. I see we have one question in the Q&A, and as I mentioned before, you're welcome to put questions in the chat or in the Q&A. The question is from Amanda, and she's asking, if I use Calis 5 milligrams to treat a fissure, must it be crushed? Is it once daily, and what duration is acceptable?
Sorry, what was the name of the drug? Calis?
Yes. Cialis, sorry.
Cialis. No. So Cialis you take orally. So you drink it orally. It's not the first line of treatment that I would use. It's very expensive. And so that one you don't crush. It's taken orally and it relaxes the sphincter from there. The ones that you would crush would be either your ISMO or Angicet if you're looking for a nitrate, or you can crush nifedipine. And nifedipine often comes in a capsule that they can open up, or there's a plain nifedipine tablet as well. What I tell my patients is they take one tablet of ISMO, they take a piece of paper, they fold it, and they put the tablet in the middle, and they crush it with the back of a spoon. So then they've got a powder of ISMO. They tip that out into a saucer. They take 2 teaspoons of whatever they can get, Remicane, anathane, and it's become quite difficult for a lot of patients to get these creams. If they can't get it, they can actually just use KY jelly. The thing that's going to relax the sphincter is the ISMO. The local anesthetic cream is really just there to sort of help them with the pain. They mix it up. Now they've got a 10 milliliter mixture. They divide that into 3 doses. So they've got a morning, and afternoon, and nighttime dose. Then they take a sort of a dose, they put it over the entrance of the anus, they take one finger, push it inside, just up to the first knuckle, take that finger out and wipe away whatever's left. Morning before they go to work, afternoon when they get home from work, nighttime before they go to bed, 3 times a day. The first time that they do it is going to be really sore. So I usually will sort of say, with the local anesthetic cream, push it as far as you can, and then stop and wait 20 minutes, then take a bit more, push as far as you can, stop and wait 20 minutes, and then normally it'll go all the way in. An easy way to get these patients, because often they'll phone you and they'll say, I have them call my rooms all the time saying, my hemorrhoids really swollen, and you talk to them for a bit, and you figure out very quickly that it's a fissure. I'll tell them to go and take a long hot bath. Not hot enough to burn them or injure them or anything, but as hot as they can manage comfortably. And the warmth and the heat from that bath will often relax the internal sphincter and their pain stops. So often they can also do that if they're having a lot of pain from a fissure.
Okay, thank you. Thanks, Amanda, for the question. I'm not sure if there's any other questions. I'm just keeping an eye on the chat, or if anyone would like to raise a hand and ask a question. We can also see raised hands.
So I also see there was a question about it. The sinus is once daily and duration is usually about a month.
Okay.
I'll manage to open the question now.
Okay. I'm not seeing any further questions on my side. So I think if there are no further questions, let me just check. Yes. Okay, yeah, I think if there's no further questions, thank you so much, Dr. Surridge. That was a wonderful presentation, and I think we were able to cover the whole topic quite well, and the take-home messages were really clear. So thank you so much for your time. And then, so I'm seeing, is there a question? It doesn't seem like a question, but thank you so much for your time. And just to everyone, this meeting has been recorded, so we'll share the recording link. And we wish you all, oh, wait, there is another question, sorry, before we close. So the question is, chronic fissures fail to respond to this, especially with sentinel fissure. So in that case, I think the question is, would surgery be an option?
So the chronic fissures, we tend to define them as being, an acute fissure is sort of less than a month, and a chronic fissure is more than 3 months. Most of the fissures will respond, 80% of acute fissures, if you read the literature, will respond to topical nitrates. That figure drops to sort of about 50, 40, 50, 60 if you look at the chronic fissures. I must confess, in my practice, I will start all of them, whether they're chronic or acute, with topical nitrates. And most of the chronics will heal on that. Usually, if I have a patient with a fissure, I'll give them a month of a nitrate. And then if they're still not completely healed, I'll double the dose. So now instead of crushing 1 tablet, they're crushing 2. The sentinel pile doesn't really stop them from healing. So the sentinel pile is just sort of an inflamed piece of skin that's hanging out there. Because often the patient will also come in and say, this thing hanging on my bum, it's really sore. And the sentinel pile is painful because it's inflamed and it's hanging off the bottom of the fissure, and it is the thing that they feel the most pain with. But it's not really the cause of any process that's going on here. So the sentinel pile doesn't essentially cause any issues here. If you fail conservative therapy, so when I've got to the end of those 2 months and I've tried the 2 the double dose of ISMO, then yes, I will take them for surgery. I will not remove the sentinel pile, because then all you've got is now you've got a fissure with an open wound next to it, which is even more painful and harder to heal. Very occasionally, if it's a very chronic looking fissure and it's got a lot of muck in the base, I'll scrape it clean, but I'll then take them to theatre and I'll Botox that fissure. I won't normally resect the sentinel pile because it really doesn't add anything. I think that was what the question was going towards. And yeah, like I said, if the Botox doesn't settle it, I'll try the Botox again. I've had probably, I think, 2 or 3 cases where the Botox hasn't worked very well. And then you go back a second time and it works really well. And I kind of think that probably that first batch of Botox wasn't good, or it had expired, or they'd broken the cold chain or something when on the way from pharmacy. So often repeating the Botox works just as well. But definitely, yes, if your chronic fissure doesn't respond, you're going for surgery. And the true chronic fissure that doesn't respond to anything is quite a difficult thing to manage. And they will probably end up with that lateral sphincterotomy. We do very occasionally see large fissures that are after a hemorrhoidectomy that fail to heal. And for those, there are bigger procedures where you start bringing down rectal flaps and sort of having to cover the fissures in tissue. They then complicate with abscesses for a couple of weeks, but most of those will heal. And you do then have bigger, more nuanced operations that you need to do for them. And yes, those ones will be heading for surgery.
Thank you. We also have another question with the doctor who's asking if anal intercourse has any impact on the incidence of piles.
So I actually tried to look up literature around this at one point, and there's not a lot of it. There's only been a couple of studies done in the US, and they're not a lot looking at hemorrhoids. So what they think in the studies is that it does cause an increased instance of incontinence. There isn't really evidence, or no one has really looked at that question, that it causes an increased incidence of prolapsing piles. Having dealt with a lot of MSM patients in my practice, most of them tend to take quite a lot of good care with themselves. If they are careful when they have sex, then they usually are fine. And there are a few tips and tricks you can give to them, and it took me quite a while to and there's nothing written in the academic literature around this. I ended up having to go to things like Cosmo and a couple of other magazines to try and get information around this. But if they use a lot of lubrication, if they make sure that they dilate beforehand, and they sort of use sort of a foreplay beforehand, even for weeks beforehand, try and dilate up, get more comfortable, put themselves in a position that they are in control of their sexual activities. So usually starting out on top. And weirdly, one of the points that I had read was, if they start out as they penetrate and they do not have an erection, then they generally have a far more pleasant, far less traumatic experience of having anal intercourse. These guys usually don't have a problem. But I think the group of patients who, I've had a few walk into my room, say to me, Doc, I just want to be checked out, and you take a full history and you examine them, and your hands on the door, and you might say, you're fine, we'll run these blood tests to make sure there's no STDs. And as they walk out, they go, Doctor, why does it hurt when I have sex? That's the group of patients that are probably more at risk of this. And I've had 1 or 2 come to me sort of saying, I want my hemorrhoids fixed because, in our community, it's I'm being called a bit of a slut because I've got hemorrhoids, which is sad, because it's not really the situation. It's just that if they learned how to do it in a way that was not traumatic, they probably wouldn't be in that position. So I'm actually not entirely certain what the answer to the question is. And I think the answer is yes, it does increase your incidence of hemorrhoids if you don't do it properly. So I think if we can advise our patients on how to do this properly, and it's a very sensitive topic, it doesn't come up very often, and it's hard to sort of lead patients into that. But yes, I think it does. And most patients, if you can sort of get them around sort of going to the toilet better, then they open up more about their sexual practices as well.
Thank you for that. I'm not seeing any other questions coming through in the chat or the Q&A. Not seeing any hands raised. Okay, I think then, yeah, we can close it here. So thank you so much, Dr. Surridge. This was a wonderful presentation, and thank you for the comprehensive answers to the questions. And thank you to everyone who was able to join today. We will be sending out the recording link.
If you do have any questions and you didn't want to ask, you're welcome to, send an email. But the Joburg Colorectal, if you just go to the website, there's an email address. You can just drop a question to my receptionist. She'll pass it on to me. I'll be happy to answer anything you want to know.
Thank you so much. Really appreciate that offer. And thank you to everyone who was able to join tonight. Wish you all a wonderful evening. Thank you. And
Thank you
good night.
so much. Thanks a lot.